Good morning, and thank you for joining Cal City's African American Caucus, A Breath of Hope. This is a webinar for lung cancer awareness. My name is Portia Middleton, and I serve as council member for the City of Citrus Heights and as the president of the African American Caucus. We know the facts that lung cancer can affect anyone. Nearly 60% of those diagnosed with lung cancer are people who have never smoked or are former smokers. And since 1987, lung cancer has surpassed breast cancer as the number one cancer killer for women. My story today is a little bit personal because my father was diagnosed with combat-related stage 4 lung cancer in 2012, and we lost him in 2016. Early detection education are key to increasing survival rates. Today, we take our part in holding space to discuss how this disease affects so many of our loved ones, identify key solutions, and ignite the ongoing conversations of taking actionable steps to support survivors and loved ones through research and quality care. We take a position to make the necessary connections to find a cure. It is an honor to welcome our special guests, Dr. Loretta Erhunmwunsee, Rhonda Smith, Chris Draft, and the American Lung Cancer Screening Initiative team, Maya and Mika. Thank you.
Thank you so much, Councilmember Middleton. Hi, everyone. My name is Marla Mateen. I serve as the Executive Director of the Cal City's African American Caucus. And I'd like to introduce you to Maya and Mika, who are the National Directors of the American Lung Cancer Screening Initiative, a nonprofit organization of physicians and students who aim to raise awareness of lung cancer screening through community outreach and collaborations with government. They are research assistants at Massachusetts General Hospital with interest in surgery, screening, and lung cancer. So welcome, Maya and Mika.
Thank you. Thank you, Ms. Mateen, for the introduction. Just more formally, we are the American Lung Cancer Screening Initiative, and we primarily have two goals. The first being to raise awareness of lung cancer and lung cancer screening, and the second to increase access to lung cancer screening amongst high-risk individuals. Next slide, please.
As shown in this graph, lung cancer is the leading cause of cancer-related death in the United States, killing over 130,000 Americans just in 2022 alone. This large death toll is more than breast, colon, and prostate cancers combined, and lung cancer is by far the number one cancer killer, but it doesn't have to be. Next slide, please. In California, over 85,000 patients were diagnosed with lung cancer from 2015 to 2019, with over 57,000 dead. These numbers from California translate to nearly 1/5 of all cancer deaths that could be reduced through early detection. Next slide, please. And so one of the reasons lung cancer mortality is so high is late diagnosis. About half of patients with lung cancer are diagnosed in the latest stage when you only have about a 6.7% chance of surviving 5 years. You have a 10 times higher chance of surviving, a truly large difference, if you detect lung cancer in its earliest stage. This is primarily why lung cancer screening is so important. Next slide, please. Low-dose CT screening for lung cancer saves lives by detecting lung cancer early. Here we have some data from the Nelson trial, a large clinical trial showing that screening can reduce between 24 to 33% of all lung cancer deaths. Next slide, please. Individuals who are 50 to 80 years old, who have a 20-pack-year smoking history, who currently smoke or quit smoking no more than 15 years ago, are eligible for lung cancer screening. This means that over 14.5 million Americans are eligible for lung cancer screening, including many of our veterans. So while these screening centers exist in most communities across the nation, these resources are still going underused. Awareness is a huge problem, and it's costing people their lives. We can reduce approximately 1/3 of lung cancer deaths, but instead, sadly, Americans are dying due to this lack of awareness. Next slide, please. In 2022, only 5.8% of all eligible patients in the United States got screened for lung cancer. When compared to the screening rates for breast, cervical, and colon cancer, this screening rate is so low. The screening rate is 14 times less likely than cervical and about 12.5 times less likely than breast cancer screenings, despite being the leading cancer death in the United States. So simply put, tens of thousands of Americans are dying each year due to lack of awareness of lung cancer screening. Next slide, please.
Here we have a breakdown of lung cancer screening rates by state. And as you can see, unfortunately, California has the lowest screening rate of any state in the US of just 1%. The national average is seen in green, again, is only 5.8%. But really, lung cancer screening in California, there needs to be a lot more to raise awareness. Next slide, please. In considering racial and ethnic disparities, Black Americans are 3 times less likely to get screened for lung cancer, and Hispanic Americans are 7 times less likely to get screened. Also, more than any other racial or ethnic group in the United States, Black Americans are more likely to develop and die from lung cancer. Specifically, 1 in 20 Black women and 1 in 16 Black men will be diagnosed with lung cancer in their lifetime. Next slide, please. At ELSI, we've directly reached over 12,000 people through community-based events. To date, we've given over 400 community presentations, everywhere from TED Talk stages to canvassing events, and even at the U.S. Conference of Mayors last summer. Next slide, please. We've also recently launched a PSA campaign and worked with over 80 mayors, state representatives, governors, and other members of Congress to raise awareness of lung cancer screening through these impactful video messages, urging people in their districts to get screened for lung cancer. Next slide, please. Also, to recognize Lung Cancer Awareness Month, which is November, we've worked with over 400 mayors to issue proclamations and city website articles to teach citizens about how to be screened for lung cancer. We've also worked with both the U.S. House and Senate in the last 4 years to unanimously pass resolutions recognizing Lung Cancer Awareness Month. Next slide, please. Thank you everyone for your time and attention. We'd be happy to work with any mayors and members of City Council to collaborate on PSAs or local events with our student teams. Thank you.
Dr. Loretta Erhunmwunsee joined the City of Hope in 2015 and is an associate professor in both the Division of Thoracic Surgery and the Division of Health Equity. Dr. Erhunmwunsee graduated Phi Beta Kappa from Emory University in Atlanta, Georgia, and received her medical doctorate from Harvard Medical School in Boston, graduating cum laude. She continued her postgraduate training at Duke University Medical Center in Durham, North Carolina, completing a general and cardiothoracic surgery residency. Board certified in both general and thoracic surgery, she became a fellow of the American College of Surgeons in 2018. Next on our special guest list is Rhonda Smith. She is the executive director of the California Health Network, a nonprofit that works to advance health equity for Black Californians, Prior to this role, Rhonda was an independent consultant and led many successful health disparities initiatives for the BIPOC community, focused on developing and implementing community outreach, health promotion, and health behavior change strategies to close the gap in disparities. Our last guest speaker today is Chris Draft. He is the founder and president and CEO of the Chris Draft Family Foundation, whose mission has been to empower families to lead healthy lifestyles. He is also the co-founder of Team Draft, leading the creation of a national campaign that is changing the face of lung cancer. He is an internationally recognized speaker, community leader, and family character advocate who serves as an NFL ambassador and national spokesperson on many health-related issues, including the care and treatment of asthma, from which he suffers, and lung cancer, the disease that claimed the life of his wife, Keisha, in 2011. Chris and his story has had an impact on just about everyone he meets, and his life work has positioned him to be a catalyst for change. And I want to take a moment to apologize for the sound discrepancy. I thanked Micah and Mika for their time, and also for the American Lung Cancer Screening Initiative for all the work. And we look forward to continuing to support their efforts. So at this time, I'd like to bring up to the stage Rhonda Smith, who will be giving us a report of the state of Black health in California. Welcome, Rhonda.
Thank you, Marla. Thank you for the opportunity to be here today. So you can hear me okay, yes?
Yes, we can hear you. Give me just one moment and then I'll remove myself.
And yes, there we go. Yes, so today, as Marla mentioned, I will be talking about the state of Black health in California. And Marla, if you can advance to the next slide, please. But before we get into some of the details about that, for those of you in the audience who may not be familiar with the California Black Health Network, we are a 40-year-old plus organization who from the very beginning has focused on improving the health and well-being of Black Californians. And more specifically, our vision is to create a California where every African American and Black immigrant has the opportunity to live a life that is long and healthy, free from violence, racism, and health disparities or health inequities. And we do that work every day to achieve and realize that vision by ensuring that all Black Californians, really regardless of how much money they make, how well educated they are, where they live, who they love, how they self-identify, and so on, has the opportunity to really have access to high quality, equitable primary as well as behavioral health care, and definitely avoid succumbing to diseases, and especially diseases that are preventable. Next slide, please. So again, I'll talk a bit about the state of Black health in California, give an overview, and then focus on some specifics as it relates to health and health outcomes for different health conditions. Next slide, please. Okay, so what is the state of Black health in California? Well, we know overall that Black Californians live about 5.5 years less than the state average. If you look at some subpopulations and compare the life expectancy of Black Californians to white Californians, that difference is about 7 years. But we believe that this number is before COVID, but we believe that COVID has added probably another year or so or to that gap. And just like in the national statistics, it's about 1 to 3 years of an additional gap in life expectancy for Black Americans. We know that Black Californians experienced the state's highest death rate from COVID back in 2020 and into 2021, and it disproportionately impacted our community. That's the bad side of COVID. I think the good side of COVID is it really put a spotlight on the fact that there are communities like the Hispanic as well as Black community that are suffering from and faced with health disparities and health inequities on a daily basis. And we know that Black Californians also have the highest rate of new prostate cancer, colorectal cancer, lung cancer rates, like mentioned earlier, as well as the highest death rates from breast, colorectal cancer, lung cancer, and prostate cancer, unfortunately. In addition, Black Californians experience health disparities and care outcomes despite the fact that we have a high rate of being insured. About 93% is reported of Black Californians actually have access to healthcare coverage, but unfortunately, we still have poor outcomes. And then the last bullet, which you may or may not be able to read well, it looks at or talks about the disparity when it comes to Black birthing people and the outcomes that we face and our communities face when giving birth to our babies. And I'll talk specifically about what those numbers are in a few minutes. So next slide, please. Okay, I guess it's slow moving today. So when we think about health inequities and how, oops. Hey, Marla, can we get the presentation back? Hello. Okay, so maybe I can still keep going on my end. I'm not sure what's happening from a technology standpoint, but I can certainly continue to talk. And so when we look at, what some of those causes of health disparities are, we know that social determinants of health contribute significantly to health outcomes. And when we think about or define what social determinants of health are, there are health behaviors, things that we can control, like our tobacco use, like physical activity and access to nutrition in some cases, and just basic lifestyle habits. When we look at other factors that contribute to health outcomes, there's clinical care, there's the social and economic factors like our education, employment, income, and so forth, and also the built environment or the physical environment that we live in. And when we think about how the social determinants of health really impact our health and well-being, we know that really, based on research, 20% really it's attributed to clinical care. When we look at the other factors, health behaviors, social economic factors, physical environment, that is about 80% of what happens or what contributes to health disparities. So when we look at this, the 80% versus the 20%, it's all those things that really happen outside of the exam room or a hospital or a clinic. And so those are factors that need to be considered when we're thinking about taking care of our community as part of that equation. And so I'm assuming, Marla, if you can text me and let me know if you can still hear me, I will continue on, but I'm not sure if I'm still being heard or seen. But I'll talk about diabetes, specifically in California. There's about 13 million adults, or about 46%, almost half of the adults in the state are estimated to have prediabetes or undiagnosed diabetes. And an additional 2.5 million adults actually have a diagnosis of diabetes. So altogether, there's about 15.5 or nearly 16 million adults in California. That's about almost half, or actually more than half, of California adults have prediabetes or diabetes. And so when we look at the Black community, yes, keep going, okay. So when we look at the Black community, Black Californians are nearly twice as likely to be told that they have diabetes compared to our white counterparts. Black Californians have the highest prevalence of diabetes. When we look at overall, it's 16% compared to all other racial and ethnic groups. Black Californians also have the highest death rate from diabetes. Unfortunately, we're 83% more likely to die from diabetes, and that's mostly type 2 diabetes compared to our white counterparts. One other health condition that impacts our community significantly is obesity. So in California, obesity affects 25% of white adults and 33% of Black adults and 34% Hispanic, and then 29% for American Indian and Alaskan Native adults. So, and that's about 10% for Asian adults. And more specifically, when we look at the Black community, Black adults with a BMI of 30 or greater, which is defined as obese or overweight, were 3 times more likely to be admitted to the hospital during COVID or with a COVID infection. The percentage of Black adults in California who are diagnosed with obesity is 33% for Black Californians compared to 25% of those of our white counterparts. And then when we look at the percentage of women ages 18 to 44 with a body mass index of 30 or higher in California, that is 34%. If you visit the Office of Minority Health's website, you'll see statistics that speak to the fact that about 3 out of 4 African American women in the U.S. are obese and overweight. That's about 75% of our female population in the U.S. So a pretty significant rate of obesity within our community, which leads to potentially other health conditions of concern. When we look at mental health, we know that there has been historically an aversion to seeking mental health counseling and resources. Unfortunately, from a generational standpoint, we see the younger generation, more the zillennials, actually gravitating towards seeking out mental health support and resources. But we know overall there is a shortage when it comes to professionals who provide, I would say Black professionals who provide support and resources for mental health. So about 4% of psychologists in the US are Black or African American, 86% is white. About 48% of Black Californians report having symptoms or some symptoms around depression or anxiety, especially during COVID. And then about 63% of the Black population in California view mental health as a condition that is a sign of personal weakness and not necessarily part of their overall health and well-being, and something that needs to also have attention in addition to preventing diseases from happening. And so, as I mentioned earlier, when it comes to Black maternal health, despite the advances and reductions in maternal health mortality for all racial and ethnic groups in California, Black mothers and birthing people are still 3 to 4 times more likely to die from pregnancy-related birth, and also 2 times more likely to suffer from maternal morbidity. Those are complications that could happen during giving childbirth, such as hemorrhaging or an infection, compared to all other racial ethnic groups. And then when we look at infant mortality, unfortunately, Black infants are 3 times more likely to die during childbirth compared to white babies. And then more specifically, when we think about women who are reporting being treated or mistreated during that experience, we see about 10% of Black mothers reporting that they were treated unfairly or related to their race during their pregnancy journey. And then about 30% of Black women who were screened for anxiety were also Black women. And so when it comes to cancer, which we'll talk more specifically about lung cancer shortly with Dr. Erhunmwunsee, when we look at the incidence rates and outcomes for Black Californians compared to other, we also see disparities there. And so when it comes to prostate cancer, we see that Black men are 44% more likely than white men to be diagnosed with prostate cancer, and unfortunately twice as likely or 2 times more likely to die from it. A similar thing when we look at breast cancer for Black women as well as lung cancer. When we look at Black Californians, they're 24% more likely to be diagnosed with lung cancer and suffer a death rate about 33% higher than the state average. As it relates specifically to breast cancer, Black women are nearly 20% less likely to be diagnosed with breast cancer. Unfortunately, they're 56% more likely to die from breast cancer. So a huge disparity there. And then, with the work that we do at the California Black Health Network, we try to go further upstream to address the root causes of health inequities and health disparities. And I strongly believe that if there was such a thing as health equity, we would not be talking about health disparities. And so when we think about the difference in the two, health equity really means that everyone gets what they need, not necessarily a one-size-fits-all approach. So there would be more of a focus on prevention and early detection, and then also access to quality, equitable care. And theoretically, there would be more lives saved and better health outcomes. So on the other side of that, we measure outcomes, which we see the result being health disparities or that gap in health outcomes and also life expectancy. But again, if we truly had health equity, we would not be talking so much and dealing with health disparities that we see in our community. And so that is pretty much my presentation for today. I hope that you all could hear me. If you couldn't see my slides, and Marla, I'm going to hand it back over to you, and then we can move forward from there.
Thank you so much, Rhonda. I really was hoping we didn't have any technical issues today, but you know how we roll. So thank you so much for that. We have to pivot, right? So
Yes.
thank you so much. At this time, I would like to bring up to the stage Dr. Loretta Erhunmwunsee. How are you?
I'm doing very well. I'm so glad to be here. Thank you.
Thank you. The stage is all yours.
Excellent. Thank you. Well, while the slides are coming up, I really do just want to say again, thank you. It's such an opportunity, a great opportunity that I relish to be able to talk with you guys. As was mentioned earlier, I'm a thoracic surgeon, so that means that most of the patients that I see are patients with lung cancer, and my job is to get them to the appropriate care, and usually with me, that is surgery, removing the lung cancer. But I also do and think a lot about health equity, and I love the way that Rhonda just expressed the importance of health equity and thinking about the upstream factors that lead us to the downstream disparities that she just talked about in such great depth. And the truth is, there are many reasons why we have African Americans having the highest risk and death rate from most cancers, but specifically today, lung cancer. And it's important for us to, I appreciate it. Thank you so much for the group that spoke earlier around lung cancer screening. That is so key. That will save lives. So I hope that's one message that comes out very clearly, is that if you are a smoker, if you are a former smoker, it actually doesn't matter when you stop smoking. Please talk to your physician about screening. So if, God forbid, there is a cancer, it's found early where we can treat it and hopefully cure it. So yes, we got to talk about screening, but we also need to talk about some of the other things that can lead to lung cancer. And so smoking is one, and that's why we use that as a factor to determine who should be screened. But we also, I think, really need to talk about how we address air pollution and its impact on lung cancer. And so again, as a health equity researcher, I think about what are the different drivers that lead to the disparities that we see. And so I want to talk today about air pollution briefly. So next slide, please. So, we're going to hammer this home today. Lung cancer is the leading cause of cancer-related death in the United States, and it's actually the #1 cause of cancer death in the world. And the truth is, air pollution is a major cause of lung cancer. And for instance, the number of estimated lung cancer deaths that are linked to air pollution has increased, and it has increased significantly since 2007. And so what we've noticed, and we are so excited about this in the lung cancer community, smoking rates have gone down, and that is worthy of celebration. It is such an amazing thing that people are smoking less, and we're really excited about that. Unfortunately, the rates of people who are getting lung cancer who haven't smoked is going up. And we feel that a strong reason for that is air pollution. And so on this slide, on the side, you see the PM 2.5, and we'll talk a bit about what that is, particulate matter 2.5. But the point here in Los Angeles, we see that the particle days, so particulate matter is like a way to measure air pollution. It's like the number of particles, of really small particles that are in the air that are part of the pollution. And we see that certainly there has been an overall improvement, you know, over the last decades of lowering this air pollution, this particulate matter 2.5. But unfortunately, we're starting to see that those rates are coming back up. And you see in this dark blue that on the bottom, that's where we consider a good number, right? Like a good amount of pollution is at that blue line at the bottom. And we see that we are now moving away from that line. And that's important when we start thinking about lung cancer. So next slide, please. So I don't know that you can see the picture, but in essence, this slide is to let us know that these particulate matters are produced by car tailpipes, power plant smokestacks, burning materials, basically by a bunch of different industrial mechanisms. And unfortunately, these particles can penetrate deeply into the lung, irritate and corrode the wall of our breathing sacs, and lead to poor lung function. And it's also associated with increased respiratory illness and death. So I think Chris talked about the fact that he suffers from asthma and is on a campaign to really bring awareness to that. Well, the truth is particulate matter, again, the components within air pollution really are associated with increased lung cancer rates, COPD, which is another way of saying emphysema, asthma, heart disease, premature death, and it's important that we understand this link because there are things that we can do about it. So if we can have the next slide. So I wanted to talk about the current situation. So I think that most of us understand, especially if you live in Southern California, that overall with really good regulations, we've had an overall decrease in air pollution levels as we've seen before. Unfortunately, there's an uptick because some of those regulations have been loosened, and so some industry regulations that were had before have been lightened, and so the air pollution levels have been allowed to come back up. And what you can see here on this slide and this slide is from this year. I think it was published in the LA Times in April of this year, and we see that there is a lot of poor days or days where there are high levels of PM, as we see on the right, or unhealthy ozone that's exposed. And we can see that, for instance, in between 2019 and 2021, each year, Los Angeles had 20 days of elevated, dangerous particulate matter levels, and that gave it a score of F. And so the reason that I want to specifically say this is because I think it is important for us to know that air pollution levels have gotten better historically, but they are worsening, and it's getting so bad that we are now back in a very horrible and unsafe range. And so when we think about lung cancer, when we think about disparities of lung cancer, we've got to be very clear about the fact that air pollution contributes to this. So can we have the next slide? And I think this slide is very telling as well. So on the left, we are seeing, and hopefully you can see this well, that so in essence, all of these columns reflect air pollution, and that's caused by different things in different colors, passenger gas vehicles in orange, or commercial diesel vehicles in a darker orange, all the way to agriculture in green. And what you can see on the left is the amount of air pollution, again, PM 2.5, which we've been talking about, that folks of different races and ethnicities are exposed to. And you can see that African Americans are exposed to the most air pollution, and our Latinx communities are exposed to the next highest, whereas non-Hispanic white individuals are actually exposed to the least amount. But when you start looking at who produces the pollution, you see that actually white communities produce most of the pollution, despite the fact that they are exposed to the least amount of the pollution. And so on the right, we see this reflected in a different way. In essence, our Hispanic and Latinx communities are exposed to 63% more pollution than they produce, right? And Black Americans are exposed to 56% more pollution than we produce, whereas the white, non-Hispanic white Americans are exposed to 17% less pollution they produce. And it's important to just like that, for instance, to me is very compelling, right? So if we believe, as I said before, that these pollutants lead to lung cancer, other cancers, heart disease, emphysema, asthma, so basically death, right? Like these pollutants increase your risk of death from different mechanisms. And we're starting to see that depending on your race and ethnicity, you might be exposed to considerably more than you even produce. That really should tell us that this is a huge cause of the inequities that we see. So if we can have the next slide. So this is some work that our team has done. So again, in our health equity research, we spend a lot of time in thinking about how neighborhoods and social contexts impact the disparities that we see. This is one of our studies that I'm highlighting today, and would love to talk about some of our other studies in the future. But today, specifically, we're talking about the impact that air pollution, again, PM 2.5, has on the risk of a particular mutation. So long story short, within lung cancer, there are different mutations, genetic mutations within the tumors that can lead to more aggressive biology or least aggressive biology. And we know that TP53 mutations, when a tumor, a lung cancer tumor has this particular mutation, that folks are going to live less, a shorter period of time. And so that means that that mutation is more aggressive. And what we found in our work, looking at City of Hope patients, looking at hundreds of City of Hope patients who had lung cancer, was that those who lived in more polluted neighborhoods were more likely to have this mutation. And again, when we take that step back and say, wait, look, we already know who's going to live in more polluted neighborhoods. We just showed it the slide before, whereas African Americans, Latinx individuals, and also those who are under-resourced and have lower socioeconomic status, it then allows us to understand that we've got to do a better job of regulating pollution so that our most vulnerable communities aren't at higher risk of getting these aggressive mutations that lead to lung cancer and that lead to higher death rates from the lung cancer. So next slide. Some other researchers have also found that particulate matter and lung cancer, obviously that there's a link, and their research looked at a different mutation, and what they found was that in people who don't smoke, and that's one of the reasons why I wanted to talk about air pollution today. One, I think we talk about smoking a lot, and the truth is, if you're listening and you smoke, please think about quitting. It will prolong your life. It will prolong your family members' lives, because secondhand smoke is a real thing. Third-hand smoke is even a thing. We could talk about that later. And even your pets' lives. We're starting to understand that secondhand smoke is bad for pets too. So the point is, if you're listening to us and you're smoking, please consider stopping and seek the help. There are a lot of smoking cessation programs, and also get screened. That's important. But we also have to understand that smoking is not the only way that folks are getting lung cancer, and that there are a lot of folks who've never smoked who are getting it. And one of the reasons we think is because of air pollution and particulate matter, which Black and brown and poor people are exposed to more. And so anyway, this work, it was an elegant study that showed that there are some mutations that you might have that might not lead to cancer directly until the pollution, that particulate matter, interacts with it, and then it can turn into cancer that we know has the highest death rate. So next slide. So, and briefly, I would tell you what I'm not. I don't have political expertise at all. But I know that hopefully there will be those who are listening who do. And so, again, as a thoracic surgeon, as an oncologist, as a scientist, our work has to mean something outside of just like academia. Like the goal is really to be able to move and make a difference and sort of broaden our understanding. And that's what this is, I hope, right now. And so what we need is partnership, right? Like we can come up with all the data and the results and all the papers, but if it doesn't move the needle, if the people with the power don't help us make steps towards good health, then Black, brown, poor folks will continue to die at higher rates. And we know too much at this point to just allow that to continue to happen. So there are lots of important legislative measures that actually have done a lot of good. The Federal Clean Air Act, the California Clean Air Act, the South Coast Air Quality Management District rules, like these have all done great things. And we, and I think again, the drop in the PM that we've seen historically has been because of this. But there are a lot of continued issues and barriers that make air pollution a real issue that we've got to contend with at the legislative level, at the population level, as well as at individual levels. There's a lot of work. Climate change is real. That's a different conversation as well. We've got these fires, these wildfires that continue to increase the particulate matter in the air. We've, because of industry, there's been an upshoot in warehousing or warehouses that again, they cause so much pollution, in California, and there's so much great about living in California, but we are by the docks where these big, boats and bring in a lot of air pollution. The locomotive, the trains and things bring in a lot of air pollution. These warehouses do as well. So, we have a bunch of pollution, and then we have our beautiful mountains that keep the pollution right here. So the truth is, we've got to partner with our lawmakers to decrease these pollutants so that our risk of lung cancer goes down, so that our health can improve. And so can we go to the next slide? I think my last one. Last two. So this is, I think, an ideal situation that we can all partner and aim for, innovative solutions for reducing PM2 levels. Obviously, cleaner energy sources like solar and wind power, so that reduces our reliance on some of these fossil fuels. Green technologies like the air filtration technologies in industry and in vehicle exhaust systems. And here's the truth: all of this costs money. Like none of this is free. And so, we've got to, again, this is not my lane. I'm no political expert or policy expert, but at some point, I think we've got to understand that the cost of a life is way more than the cost of any of these other measures that could prevent death. And so if you really do that cost analysis, I think doing the right thing with cleaner energy and greener technologies would put us in a better place. And then we got to invest in research, please, and the development of sustainable practices like, like a beautiful place like this that promotes green spaces, pedestrian-friendly designs, efficient public transportation, and equity. I think what we could imagine is a place where communities really are, they co-design environments where they can afford and not be driven out, and that allows us to live more healthily. And then my last slide, the next one, I think, yeah, call to action is, we got to do the things. We got to, so to consider public transportation, reduce energy consumption, support eco-friendly initiatives. We got to increase awareness, which is why I love having conversations like this. Advocate for clean air, we've got to. And then, lawmakers prioritize and enact stronger regulations. I know Marla is one of the leaders of one of these organizations that really is pushing forward environmental justice, and we all need to partner so that we can get to good health. So anyway, that's it. Thank you so much, everyone. Thank you.
Thank you so much, Dr. Erhunmwunsee. That was beautiful. And yes, I am. I serve on the board for CCAJ, the Center for Community Action and Environmental Justice. And out here in this region, it's been an epidemic with warehouses popping up, causing more truck traffic, and of course, it leads to more PM 2.5 in the air. So we're definitely fighting against that so that we can have cleaner air to breathe.
Thank you.
Thank you. So at this time, I'd like to share a brief video before I pull up our next guest. Chris Draft is the founder of Team Draft, and he will be up in just a moment.
Hi, my name is Chris Draft, former NFL linebacker. I faced a lot of tough opponents on the field, but nothing as big as the issue that we're tackling right now. Changing the face of lung cancer. Why Keisha passed away of lung cancer at 30 years old. She was strong, she was healthy, she never smoked. We're leading a campaign through Team Draft to change the face of lung cancer and bring hope. But to understand the hope, you understand the stakes. Excuse me, ladies, can I ask you a couple of questions? Excuse me, would you be willing to answer a couple of questions? My name is Chris Draft.
Lauren Germinari.
How you doing, Lauren? If I asked you, what is the biggest cancer killer of women?
Ovarian cancer. Breast cancer.
Breast cancer.
Breast cancer?
Now, why would you say breast cancer?
That's the one that I've been most aware of.
Did I see it on TV?
Lung cancer actually surpassed breast cancer in 1987 as the biggest cancer killer of women. What do you think about that?
Oh man, that's crazy.
I'm the only in the world. On the left.
You think it's the biggest cancer of men?
I think it's prostate cancer.
Testicular cancer?
Prostate, I guess.
Why would you say prostate cancer?
I feel like I've seen a lot about it on TV, NFL specifically. You can have their little blue ribbons.
Biggest cancer killer of men, lung cancer also. What do you think in terms of that?
Oh, that's another eye opener too. I guess it affects all walks of life, men and women equally, huh?
What's the biggest cancer killer overall?
Can I Google it?
I don't know.
Yeah, Google it.
Probably skin cancer.
Maybe lung cancer?
Let me see the Google lady over here.
Lung cancer accounts for 28.3%.
That surprises me because you think of people not smoking as much and so therefore they're as susceptible to lung cancer.
Did you know people that don't smoke get lung cancer?
No, I didn't know that. No, I thought it was due to smoking.
I think you'd have to go with the classic smoker image. People who have chain smoked all their life who develop lung cancer. I think that's kind of the stereotypical lung cancer patient.
Overall, as lung cancer, it kills more than breast, prostate, colon, liver, kidney, melanoma combined.
Wow.
You do not have to be a smoker to get lung cancer. I don't understand why there isn't more awareness or more energy around that fact.
I can't say that I remember seeing a lung cancer ad or awareness lately?
You need to have a campaign and a brand just like breast cancer does. I think they're a good model to go after since they've been so successful in raising the awareness.
We could change these stats by funding more research. Visit teamdraft.org and join the team to change the face of lung cancer. I'm Chris Draft, and I know that it takes a team to tackle lung cancer.
Thank you for showing that video, Marla, and I appreciate you for the invite. Maya Sharma is on here from ALSI. She's another person that connected me with this opportunity. So thank you for having me on, and thank you for having this discussion during Lung Cancer Awareness Month. The video, I think it speaks for itself. I actually made that video in 2013 as a kid, and we presented it at the Super Bowl. Super Bowl that was in New Orleans, and what I'd found over the previous year, or I would say the year after my wife passed, my wife was diagnosed December of 2010, actually 2 days after Christmas. Was in amazing shape, 37 years old, didn't have a history of smoking, and was diagnosed with lung cancer. And before, after having a PET scan, I found out it was stage 4 lung cancer. The great thing is, that there was progress, there was innovations that were there, but unfortunately for her makeup made it where those weren't possible. So she ended up with standard chemo and radiation, and ended up passing a year later. But before she passed, we got married. We got married November 27, 2011, and on that day, or before that day, she asked me, said, "What if we don't get presents? What if we ask our family and friends to support the foundation?" And that really the supporting the foundation was for us to be able to join with the community to fight for other people that are impacted by lung cancer. And so I said, absolutely, baby, I'm with you. And so we asked our family and friends to join us. And so on our wedding day, we actually made 2 commitments, one to the lung cancer community, and and the big one that was to each other. And I say that story, as I work my way back, is that so often people, they don't give my wife credit. They don't give her credit for the fact that it was her who came to me and said, that she was ready, and challenged me to stand with her in fighting for the lung cancer community. And so as you guys are out listening, I hope that you'll make sure that you take a note of that. But even before that, I have to say that my wife had an amazing team. Had an amazing team around her where we really did need more support. We needed the medicine to work, but we did need more support. We had a tremendous relationship with her primary care doc. She was very honest about her feeling the shortness of breath when she went in. Got in there right away. Her primary care doc ordered a chest x-ray, didn't say, "Oh, just come back." Ordered a chest x-ray, said, "Let's just check it out." And that's how we found out she had a mass in her left lung. Primary care took a lead, quarterbacked getting a biopsy right away. Got that 2 days after Christmas. He ordered the PET scan. Well, we got that before our first visit to the cancer center. We already had the PET scan. So many of the things that we needed were fast tracked because our primary care doc took a lead. And I can say that is absolute privilege. Along with being able to live in Atlanta and living downtown, made it where we had the privilege of being close to Emory that had already bought into the progress around lung cancer. And so I say that story as a backdrop for the fact of then We're talking about changing the face of lung cancer, and that it's important to understand the facts as you saw in that video, but really just understand what's going on, understanding the truth about lung cancer. Do we want to? And is it worth learning those things? Are the people worth fighting for? So I think as we're on this, I'm excited about being on this call, because this call means that the people are worth it. They are worth fighting for. And in that means that there are things that we can do and things that we've known and we've proven work. All right. So getting people to stop smoking has been proven to work. That is a great thing, a wonderful thing. We know that air quality has been huge, that issue. I grew up in Southern California. It is so critically important to be able to get that down and get that controlled. The other part is just pollution and workplace issues and understanding those impacts. Well, literally, those have been a part of the lung cancer story for the longest time. The difference has been the change that is about really identifying our survivors and understanding that they're worth fighting for. And so going around in Denver, as I refer back to the video, was really going around to ask people, do they know the numbers? But it really wasn't just about the numbers. It was really to acknowledge to our lung cancer community that too often people are saying, how do they not know that lung cancer is the biggest cancer killer? How do they not know that lung cancer kills more than breast cancer? How do they not know that lung cancer is the biggest cancer killer of men? Well, because we didn't tell them. We didn't tell them. And so as we're here on this call, I hope with everybody's comments, that what folks know is there are things that we can do and they're worth doing. That people, not just ones that have gotten lung cancer because of not having a smoking history, but people who have a smoking history are worth fighting for. In 1998, the cigarette industry got indicted for over $200 billion. Our people are worth fighting for. And so the numbers were just a nice reminder of that it is real, that this is something that is big. But the question that we've had to answer, that I've been challenging people over the last 12 years, is, are the people worth fighting for? But are we willing to put that into action and get it done based on what we know has changed? And that is, we can do more than just prevention. We can have nodule clinics, we have screening, we have treatment options with targeted therapy, with immunotherapy. We have research with clinical trials, and we have, through our survivorship programs, that we can change how people live during that diagnosis. So thank you guys for bringing this together, and thank you guys for your commitment. And hopefully what we're doing here is just going to be a challenge. It has to be a challenge to action, and that action that we recognize is about saving lives, which is an amazing thing. Marla.
Absolutely. Thank you so much, Chris. And I just also want to thank Maya and Al for connecting the caucus with you and the work that you're doing. And we definitely want to continue on this road with you and make sure that we're bringing awareness and coming to actionable steps that will provide lives to be saved. So at this time, we're going to go ahead and transition to our discussion. I'm going to bring up Dr. Erhunmwunsee and Rhonda. And I just have a few questions, and in the mindfulness of time, I'll go ahead and popcorn it to you, Chris. How can we ensure that we're raising awareness regarding lung cancer, not just during Lung Cancer Awareness Month?
I think that's an easy answer, is that recognizing that people don't just get diagnosed in November. And awareness is not just about like public awareness, but the awareness that happens too often is really an awareness that there's hope. And so anybody that is diagnosed needs to know that there's hope, along with the fact is how many people, regardless of it being lung cancer, actually know how to navigate the system, the health system in terms of cancer. So I would say that if we look at awareness just as this thing that says, hey, lung cancer, that will get in the way, versus recognizing that lung cancer awareness has to be making sure people, when they are diagnosed, that they are surrounded by love, that they are surrounded with information, and they are encouraged every day, as an individual and their family and other people, that there is hope and we got you.
Dr. Erhunmwunsee, you spoke about the impacts that our environment has on our lungs, hence the particulate matter 2.5. What are some viable ways that we can mitigate our exposure?
Yeah, no, excellent question. But I want to just start by reiterating what Chris said. And so I really appreciate the fact that, one way that we increase awareness is like throughout the continuum, before the person gets lung cancer to after they've got it. And we've got to include that. We got to understand the caregivers, the people that love the folk who have the disease have to be supported. And so again, thank you so much for all that you've brought to this community, which kills so many, and it doesn't need to do that anymore. So the way we reduce or mitigate the impact of air pollution, and we got to reduce the levels of air pollution. We got to just do that work. And so again, partnering with our legislators and that's one thing. Policy, regulations, and really in advocating. I think number two is maybe some of the things that we can do locally or with our own individual sort of spheres is what are we doing? Maybe I think filters. I have filters throughout my home, and just because indoor pollution is a big cause. I think too, like being cognizant of the air pollution days. I think most of us have apps and the phone that tells us when pollution levels are high, and considering what we do, how we navigate that day, and being outdoors and mask and not mask. I think there is, being a part of the solution, and really like how do we change. I think we've got to be, so I believe as a health equity researcher, being disruptive. So we've got to, the way we're doing it isn't working, right? People are dying because of industry and because of pollutants. And so maybe we've got to start mandating legislation that makes it so that these filters and these different energy sources are a part of like the way it is. Like we just got to push for that. And then I think again, some of the work that you are doing, advocating for, like getting these warehouses to be a thing of the, to be less and just really supporting policy. So I think those are some of the things.
Thank you. Rhonda, what are some of the action steps that California Black Health Network takes in determining eligibility for receiving support?
Yeah, so one of the ways that we provide support is that we are a Covered California navigator. And so we know that health equity begins with access. So we are able to enroll people across the state, regardless of who they are and what their race and ethnicity is, in healthcare coverage. In California, it's access is even better because we know that folks that are undocumented can also get access to healthcare coverage and what they need. So that's one way that we're providing services to ensure that at the very least, people get access. And then there's navigating the healthcare system. I think Chris mentioned that as it relates to lung cancer, but we know that people have a hard time navigating the healthcare system just to get their basic needs met. And one of the things that we're doing as part of our education initiative is partnering with the California Healthcare Foundation on their How Do I campaign, which is an outcome of their research report or study called Listening to Black Californians, and really trying to get a handle on and gaining greater insight and understanding as to what is happening with Black Californians when they interact with the healthcare system, and what are the issues and challenges and barriers that they're confronting when they do that. And so one of the things I like about it is it revealed a lot, but also it's not going to be a nice shiny report that resides on the website or on a desk or shelf somewhere. We're actually taking actionable steps to address some of those issues that came out of that report. So we will be uplifting, launching, and implementing and moving forward the How Do I campaign to help people really understand those basic things, like what are their patient rights? How do I navigate through the healthcare system? How do I have a conversation with my healthcare provider? How do I get a second opinion if I receive a serious cancer diagnosis? Or people knowing that they have the right to do that, right? Or even ask their provider questions, or what questions to ask. So we really want to empower people with the knowledge, tools, skills, and capability to really be their own health advocate and really be at the center of decision making for their care, and really own that, no matter what health condition they're dealing with. And just one more thing I wanted to say, what Dr. Erhunmwunsee talks about is really related to the social determinants of health and like that built environment. And I know, Marla, you've had your own personal experience in dealing with, you know, the particulate matter that is released when there's a bunch of trucks driving through your neighborhood. And so those are things that we don't really talk about, right, when it comes to how the environment and even climate change really impacts Black and Brown communities. And so even with the work that I do, I don't even know, like, what is the screening that happens for lung cancer? Like, how does that happen? You know, what is the screening mechanism for lung cancer?
Oh, yeah. And I'm happy to talk about that briefly. So it is recommended to have a low dose CT scan. So it's a CT scan that has a lower radiation dose. And we recommend having that annually for those who have a smoking history, right? And so that is the way it gets done. And so the low dose CT takes seconds. It is much easier than a mammography, certainly easier than a colonoscopy. It is a CT scan and that's how it happens.
Right, but sorry, Marla, I think this is important.
No, you're fine. This is what this is great.
So if you're saying that what we are seeing in terms of the majority of the cases of lung cancer really stems from environmental exposure, but you're saying the way it works in the healthcare practice is that screening doesn't happen unless there's a smoker. So what do we do to address and shift the mindset?
That's a great question. I want to say two things. Number one, the number one cause of lung cancer is still smoking. Period. End of sentence. Number one cause. And so the screening that we've all been talking about is based on smoking because, you know, when you create a screening mechanism, you don't want to over screen. And folks realize that, you know, that still your rate of getting lung cancer is low if you've not smoked. Now that's changing. So that's one thing. Smoking is the number one cause. Our lung cancer screening right now is based on smoking. But Rhonda, to your point, which is a beautiful one, there is a rise in folks getting lung cancer who've never smoked. So we've got to figure out how to screen non-smokers and never smokers. And there's a lot of work looking at risk assessment, like trying to figure out the risk based on your air pollution exposure. Real talk. And so that's where the research and that's where the trials are right now. Like we're trying to figure out, you know, and that's some of the work that we've been doing, like, hey, how does it really influence and how could we use that to determine who should be screening? So we're not there yet, but I do think we will be getting there.
Yeah, it's such a great point. But if I could just tap in on that, is that the group that can benefit right now, I want you to think of them as the veteran community is the biggest kind of subgroup that can benefit from it. When we look at smoking history, that's what it looks like, right? And so as we are making the adjustments, you know, I challenge people all the time that, you know, my wife was diagnosed at 37 years old, which means she wasn't up for mammography. She wasn't up for colonoscopy. So there's always going to be a kind of guidelines as it relates to that, and those guidelines will change as we've seen over these last 12 years. Have they've changed with mammography and colonoscopy? Those they have, and so lung cancer is in that same place. I would say that early, you know, when my wife was diagnosed, the idea of thinking about lung cancer outside of connection with smoking was blowing people's minds. Like they were looking at me like, oh my goodness, and they're shaking their heads and say, well, you know, it can happen. Let's do the research on it. So it needs research. We have to believe in the research so that we can adjust the models, which has happened. And so initially lung cancer screening was for 55 to 74. Now it's 50, you know, so it's 55 to 74 with a 30-pack year smoking history. Now it is 50 to 80 with a 20-pack year history smoking, with basic adjustments potentially with some other risk factors. So things have already changed. Again, just know that there's a group of people that we've already proved got taken advantage of. They can benefit from it. It gives us a chance to save lives. And we need to save the ones we can on the way to saving more.
So Dr. Erhunmwunsee,
and I just want I just wanted to add that, with those guideline changes from the American Cancer Society, I think this is going to be a good opportunity, excuse me, for our legislatures and our policymakers to push for the guidelines for people to have better access to that if they've never smoked before. So I know, if you have been or were a smoker, like, if in my example, I was raised around smokers. My grandparents all smoked. My grandfather was a veteran. So that secondhand smoke also could contribute to something in the future for me. So it's like, how can we advocate more for those who might not be aware that this screening is available to them based on those particular guidelines?
Right. Do Dr. Erhunmwunsee, do you think that, are you familiar with multi-cancer early detection technology?
Yes, right.
Do you think that that could be one solution or an option for screening? We know it can detect over 50 different cancers. I think lung cancer might be one of them, but would that be an alternative maybe?
Yeah, no, I think certainly maybe. I think, like we were saying before, needs to be a bunch more research on it. I think most of these technologies that you're referring to are serum based or serology, so basically through blood. And sometimes you can have an early stage cancer that is not shedding in the blood, and so you still may not be able to catch it. And so I think I like the way Chris, you framed it. It's like, let's do what we know to do right now as we expand to increase the impact on others. And so, right, I think potentially one day, but certainly it's not ready for prime time quite yet. And I want to just circle back, Marla. You said something I think is key. There are, like, and Chris just named the eligibility, and our partners from ALSI mentioned them as well. But there's always other risk factors, for instance, and family history. So if you go into your doctors and say, hey, look, I have one generation of lung cancer diagnosed early, and I have secondhand smoke, and I've got, these other factors, that you can be considered for screening. And I think that is something that is important to let people know. And in essence, also, if you're concerned, I think sometimes, right, like it's a conversation with your provider.
I'd like to also bring up a point, in 2020 during the COVID-19 pandemic, how did that exacerbate any of the lung cancer diagnoses or screenings? Was that a factor as well, particularly in communities of color? Because historically, our communities, we distrust the healthcare system, we distrust the government. So historically, I want to know, was there an uptick in any correlation to the patients that you were seeing with the virus as well?
Yes, unfortunately. So let me be clear about this. So during COVID, a lot stood still, right? And for instance, we have partnership with two of our federally qualified health centers in our community, and we've started lung cancer screening programs at those facilities because they serve marginalized, historically neglected communities, and they didn't have programs before. And then when COVID hit, the screening stopped. Folks weren't coming in. Radiology, folks, it was all like shut down. And we know that there was an increase in sort of late diagnoses because people were screening less. And I think we're still seeing that, even though it's trailing off, we're still seeing some of the effects of that. So to answer your specific question, screening went down universally during COVID. I saw it with my own eyes. Our screening programs came to a near halt because people were just like, I'm not sick. I'm not going to go out there and get sick. So I'm not screening right now. Forget what you heard, And so but then when we started screening again, like, stuff was more advanced. We saw, and so that's always a concern, especially in our communities that have other things that are piled on top of what we're experiencing.
Thank you for that. So at this time, I know we're getting close to our cutoff, and I want to bring Maya and Mika back up, and then I'd like to do a round table of just a couple of points that the you plus LC team, they what you all would recommend or suggest that we do to continue this conversation and to continue to advocate for survivors and loved ones who have lost someone to lung cancer. So, Chris, I'll start with you. What are a few thoughts that you have to you?
I guess I'll go back to the first question that you asked me, is that I think when we're looking at Lung Cancer Awareness Month, that we have to see it really actually different as a Lung Cancer Education Month, and really ask ourselves, are we educating people right now so they, if they are diagnosed, that they can handle it? So what can we do? And I think, that's why the ALSI students are so important. How are we educating people at university? How are we educating them in high school? How are we educating them in middle school? Are we preparing people to be able to navigate the health system? And then my last point would be is that we need to make health a priority. Right? I've apologized at times for the fact that I played in the NFL, and people will say, "Why do you apologize?" I said, "Well, I apologize for the fact that somehow people think that the NFL is the ultimate goal of playing football. And if that is, then we are destroying our people. That health, playing sports has to be about health, right? And then once we lose that, what we do is we have a great opportunity of preventative care, but we're throwing it away because we think we have to get a trophy. Well, the trophy is health. That is our trophy. So we need to make sure that we focus more on that. And so as we're playing games and running around, we need to celebrate the fact that the kids are winning just by being out there. That is winning, physically, mentally, emotionally. And, they get a trophy for the game that they're playing. Man, that's great. But before they even get there, they've already won. We've already won.
Mm-hmm. Thank you. Dr. Erhunmwunsee.
Yeah, thank you. So again, I just want to say thank you to the panelists, and thank you, Marla, again for the invitation. I think if I had to think about the most important points, one would be that the health disparities that we are experiencing and are seeing are preventable. And we got to know that it's not a foregone conclusion that it has to be that Black men have the highest risk and the worst death rate. It doesn't have to be a foregone conclusion that Latinx communities are going to have the highest exposure to air pollution. And I think sometimes we see disparities and we think, well, that's just the way it is. And it's like, no. Like, we have control. And I think what I hope for us is that we understand our own individual and community power. And that's why panels like this are so important. It's like, I know what you know, and you know what I know, and let's go know it together and go do a thing. And so I think, just know that it's not a foregone conclusion. That's one thing. Number two, I will always say it every time. If you are smoking, please seek help to stop. There's nothing else, and I want to make sure I'm not lying. There's nothing else that you can do that will harm you more, right? Like, there probably is, but smoking is also like that thing. And so if you're smoking, seek help in stopping. There's so many programs at City of Hope. We have smoking cessation programs, but all major academic institutions and community institutions have these opportunities too. And we want you to live longer. It's not just about like out there. We want people to live longer from lung cancer. We want you, each individual, watching us to live longer. And that means that if you're smoking, that has to be a thing of the past. And it's hard, right? These smoking companies knew what they were doing. They did it with intention to make their banks large and honestly to lead to death. And so we know it's difficult. Partner with us and with your physicians in getting smoking and stopping. And then the last thing I always say whenever I'm given the opportunity is that please, even, and this is, I hope we get to a point where our primary care physicians are like, look, too many people are asking me about lung cancer screening. Can you stop it? So, but until then, every person who's ever smoked anything, please talk to your primary care doctor about lung cancer screening. Just ask, and then have them say, "Well, you only smoked 2 cigarettes when you were whatever is you meet eligibility." But until then, if I want us to inundate our doctors with like the awareness that it can save my life. So let me just ask about it, right? Just like women, we're going to get our mammograms, and every person with a colon needs colonoscopy. If you've ever smoked at any time, ask and have someone else tell you maybe you smoke too little or whatever else, but ask about it. So anyway, those are my thoughts. And again, thank you guys for an exceptional panel.
Thank you. Rhonda.
Yeah, so I echo what Chris and Erhunmwunsee said about the awareness and the education and programs. And I think the thing to add to those elements is around policy, right? So we can have all those things in place, but we know that policy makes lasting change. And so we were, part of support for Proposition 31 in California, because we know what big tobacco has done in terms of the predatory marketing practices in the Black community, tobacco, and specifically menthol cigarettes. And so we work a lot to not only uplift our community's voice, but hopefully engage our community. And I say, let's go back to the 60s when we were all activists around driving change so that we, can see and have a different life experience, right? And so I think it's up to us to take ownership of our health. It's up to us to advocate for change that we need to see in our communities and get involved so that you can limit the number of industrial facilities in your community. We do have a voice and a say in making that possible. So that's what I would love to see. And I think that's an important part of the process is, more community engagement around solving some of our own problems and addressing some of these issues in our communities through policy.
Thank you. Mika and Maya.
First, I just want to say thank you for the opportunity to be a part of this panel and just to learn from everybody here. Surrounded by very accomplished individuals, and I think as a student, sometimes you don't feel like you can really you make a difference or but everybody plays a part. Everybody should feel that their voice matters, because lung cancer is very stigmatized. We all spoke about the fact that it doesn't get enough awareness in the media, it doesn't get enough awareness in our education. And I think that we all realize that we collectively have the opportunity to make a difference. We can help fight the stigma. We can help increase the screening rates, because while we have this technology of screening or advancements in treatment, advancements in surgery, in a way, none of that really matters if people don't trust that it's the right thing to do. So everybody can play a role in raising awareness and helping fight the stigma against lung cancer.
Mika.
Yeah, to echo what I've just been saying, it's important to understand that you have a role to play with your own health, and you have the ability to be able to get screened if you meet the criteria. And if you are a smoker, I really recommend you try to stop smoking as soon as you can. It will benefit your life. It'll prolong your lifespan. The experiences that you will have in your lifetime, in your precious lifetime. So, thank you very much for coming onto the panel, and I appreciate the experience.
Thank you, Mika. Thank you, everybody. I'm so grateful that you all answered the call to do this with the caucus today. I just want to make mention, and Chris and I have talked about this at length, so is Rhonda and Dr. Erhunmwunsee. We have to take the actionable steps to move forward, and we have to hold our leaders accountable. So when we say we're going to do something, we do it and we follow. And that's one thing I want to encourage everyone listening today is to go on to teamdraft.org, go to City of Hope, go to California Black Health Network, go to American Lung Cancer Screening Initiative, all of our websites, so you can learn more and be empowered to advocate not only for yourselves, those that you love. So I just thank you all. I thank everyone for tuning in today and those who will watch the replay, and visit calcitiesAAcaucus.org, and we'll have more information up in our newsroom pretty soon. And until next time, thank you all.
Thank you.
Thank you.
It's fabulous.